Yes, I'm happy to introduce Dr. Arie Zakaryan. Dr. Zakaryan is a psychologist with clinical specialization in pediatric psychology and pain management. He received his doctoral degree with a child clinical subspecialty from Loyola University, Chicago, Illinois. He went on to conduct his pediatric psychology internship at Rush University Medical Center in Chicago. Dr. Zakaryan completed his fellowship in pediatric psychology at Children's Hospital of Orange County in their co-occurring clinic with a focus on treating patients with co-occurring medical and mental health diagnoses, especially for youth diagnosed with cancer. He also is fluent in Spanish and Armenian and conducts assessments and intervention in Spanish. Dr. Zakaryan joined Phoenix Children's Hospital in 2017 and is a psychologist as part of the pain medicine program. Welcome.
Yeah. Okay. Thank you. So I'm very excited to be here. Thank you for inviting me to talk, and thank you, Denise and Softbones, for that lovely introduction. So I am over at Phoenix Children's Hospital. I work with Dr. Navesa very closely and with Dr. Smith as part of that kind of multidisciplinary team to help treat patients with hypophosphatasia and other bone-related disorders and mostly chronic pain for my patients. Disclosures, my disclosures slide went away, so I'm not sure what I did, but I don't have any disclosures. I am not a physician either, so I won't be really talking about medications. And then there's a lot of non-pharmacological strategies, like also PT and OT, that I just won't be able to really delve into, but they are just as important as things that involve psychology or coping skills. Yeah. And so the objectives, and apologize that it said hypophosphatemia or hypophosphatasia, I meant to do that, but we're going to review the prevalence or how much of that pain kind of is reported out there for folks with also those bone-related disorders, because with the small kind of samples and population in HPP, I've kind of expanded it to be able to get enough kind of data and review. Then talk about basic theories about pain and pain models, and then discuss some of the different coping skills that we can use, first by age and then by kind of type of category. Then, so looking at prevalence of pain. So in one small study, it was of 52 adults. Pain was reported, though, not surprisingly, in almost 91% of patients, right? So that is clear that is something that's a big thing that we need to be discussing. And then in a different study, about 62% of the OI patients, osteogenesis imperfecta, reported different levels of pain, a quarter of them being acute pain. So acute pain is like 3 months or less. And then about a quarter of them with chronic pain, which is about 3 months, lasting 3 months or more. And then a mix of that acute and chronic. And so this also just gets tricky too when we think about chronic recurrent pain. That can kind of come and go in that way too, which adds another layer to it. Other considerations to be mindful of is that there could be structural kind of concerns related to the spine and joints, osteoarthritis for the spine and joints, and other oral health or dental kind of implications. And so even with that, one small European study found that oral quality of health was worse for different psychological functioning on X-linked hypophosphatemia, XLH, compared to the OI participants for that study. And then looking at also what kind of is going along with pain and these other kind of bone-related diseases. One study was reporting how there was a lower quality of life for adults with XLH, and then the kids and teens also in that kind of interview study. Subjective study was reporting similar things for OI. And unsurprisingly, because any of these conditions are not just a physical condition. Also, things like anxiety and distress, low self-esteem were other factors that were involved in occurring at the same time. Also, kind of that feeling different and not feeling typical as your peers, as you're transitioning from being a kid to a teen and beyond. And then, of course, pain commonly affecting our mood and mental health, and affecting how we can live our vocations, whether that's as a kid and teen, your school, or as an adult, different volunteering or work kind of aspects to kind of live out your life and function. Not only for the patient, but then also it's going to be thinking about for the parent, if it's a kid or a teen. Their work is also affected. And with a patient, frequent interruptions for school, frequent interruptions with education and work. It's just a really changes your life, trajectory, and we want to be really thoughtful about that. And it's not just about the medical symptoms. The other thing, though, that I like to, I think this is the, I was trying to find the little clicker, or the thing is the resilience. Like that is something that was also in this study noted, that there is this strength of resilience that we can't also lose. And I really like to ask all my patients about 2 or 3 strengths that they have, because you never know when you can tap into those strengths for treatment success. So I think that that's something that's important to keep in mind and be thinking of. Then, before we get into gait theory, I realized after the fact that I already sent the presentation is that another big framework that I think about is the autonomic nervous system. So that's like kind of the part of our nervous system that controls a lot of the automatic functions: breathing, heart rate, digestion, immune system, sleep, pain, stress, anxiety. It's like our survival instinct, that fight, flight, freeze. And then on the other side, the rest, digest. So that, I think, is, in my biased opinion, the crux of like what I'm working on and all of a team that we're working on, because people who, by the time they come to us who have chronic pain or other chronic illness, have been traumatized in the healthcare system, let alone traumatized in other ways, as well. But until we can kind of help with that regulation, it's really tough. And not only is that fight, flight, freeze going to be something that we see outwardly, but even in small little ways of how we interact with our loved ones, our parents, our siblings, our friends. And if we, as much as we might regulate ourselves individually, using all the coping skills we can, we won't reach that optimal rest and digest until our environment also regulates and co-regulates with us successfully. So it's a really tricky thing to do, and no one is perfect. That's another big piece, is not about perfection. I like to joke that it's about the 4 Ps: persistent, practice on purpose to make permanent, is what we really want to kind of strive for and achieve. So working as a team with patients and parents and families is a big portion of that. So then, coming now back into gait theory. So this is just more about kind of thinking about pain and some of the things that have come up with that. This is something a little more recent, since 1965, and it's looking kind of to think about how there's a neural gate in our spinal cord. Again, not really a gate, but how our neurons will like send messages chemically and electrically, and like the neurotransmitters, and how those can open or close and modulate how we perceive pain. So this is kind of one of the beginning times where it was acknowledging the effect of psychological impact on our perception of pain. So the gate can be opened by, So medical, physical things, clearly, like fractures or illnesses or injuries. It can be opened behaviorally by, lack of sleep, poor diet, poor hydration, not getting and moving around as appropriate for each patient. And then emotionally, feeling sad, mad, stressed, or scared is going to open our nerve gate and like kind of flood the brain with more pain. Then to help close it, medically, physically, medications, anesthesia, numbing creams, or something like that. Behaviorally, getting good sleep, not focusing on the pain and not with our language and our conversations, and focusing instead on functioning, using heat packs or cold packs. And then emotionally is going to be feeling happier or feeling relaxed or calm, and bringing in humor and all those things to help close that nerve gate little by little. Then kind of thinking about the team and the treatment approach is definitely an integrative approach, where we're going to have a lot of kind of multiple disciplines. So not meaning punishment, right? But different experts coming together to help manage the pain at different levels of the body. So we definitely have our MDs and DOs, our physician colleagues, who are going to be experts to help and think about the body at the level of the biology and chemistry. Our nurses and nurse practitioners who are crucial to our teams as well. Psychologists and other behavioral health providers who are going to tackle things at that level. Physical therapy and occupational therapy, thinking about different complementary and alternative medicine providers. We're really lucky at Phoenix Children's that we have at least 2 doctors of osteopathic medicine, DOs, who are practicing OMT. So we're able to offer that osteopathic manipulation treatment that Dr. Genovese was talking about earlier. So that's been really helpful for our patients. Child life specialists, of course. I think I've been talking with some few folks here and how crucial they are to make sure to help try to hopefully minimize that trauma that can happen in the healthcare system. And social work providing resources or other things, because we know that stress isn't, again, just about our medical needs, but also just even our basic like human needs that are sometimes people are having a hard time with. Oh, and as well, of course, our patients and families are going to be the experts on the team as well that we're going to need to work with. And so physical activity, this is going to be a brief slide, but it's going to be appropriate physical and occupational therapy. Aquatic therapy is another go-to that we try to incorporate if as possible, to help like reduce that kind of pressure and of gravity on the bones and joints. And then appropriate exercise. Then now, kind of because being a pediatric psychologist, I'm going to focus a little more on pain, but I think that this can apply for basically almost all of us. Kind of thinking about, what are different factors that might start off this event? Like, again, triggering events and stressors, whether it's fractures, diagnoses, multiple ED visits, or something like that. How do we cope with things? Do we avoid? Do we attribute it to certain negative issues? What are some family factors? After we don't do very much, do we decondition in our body? And so then we become weaker and our baseline gets lower. Other psychological events, aka thoughts like catastrophizing thoughts. I'm getting really worried about our pain. And just noticing that there can be other school absence and enmeshment within the family and different high healthcare utilization, which again is the health system, unfortunately, kind of training patients to like keep on, going to a doctor, going to get tests, and going to, the ED, which can be a stressor each time, and like again, activates that fight, flight, freeze response every time. So it seems part of the system, and we have to kind of acknowledge it and try to like help turn it down little by little. And just the goal to kind of come back to functioning for the child or whichever patient. I also like to kind of put people in the context of a family, right? Because we don't live on an island by ourselves. We're going to be kind of a social species. So kind of thinking about, this is from Dr. Palermo, who's a pain psychologist in Seattle Children's and her team. And so thinking about family level variables. So like thinking about like life cycle stage, for example, would be like maybe if parents are young parents, so this is their first child, so what am I going to do? Am I doing it wrong? Am I doing it right? Or maybe older parents or parents who had children through IVF, so now this is like a miracle child. And so of course we can understand and like give us a context for the maybe worries or catastrophizing that could come up. Or different parent level variables, so what is their medical history or what is their mental health history, how that could affect. And then within the child or the patient, developmental factors, how is their biology or physiology, what's the emotional state, and what are their behaviors that are going on that's kind of interacting all together. So these are kind of the models. Now we're going to kind of think about the different coping skills by age first. This will be maybe a little faster, and then we'll get into more in depth when we go by category. But the first one is thinking about infants and babies. And so there's actually a lot of research that breastfeeding and sucking is just as effective or sometimes more effective than things like Tylenol when getting vaccinations, whether it's in the NICU or in other kind of immunizations. That mother's touch, that maternal touch, and that kind of connection is a big piece. Because if we think about it, every time a baby needs to do anything to survive, they get into their fight, flight, freeze mode, and it's either their mother or another adult caregiver who's helping them regulate thousands and thousands and thousands of time to get into that rest and digest. And not just for 1 year or 1 month, it's like for multiple years. So we always seek that kind of over and over again to kind of go back if we're in a stressful response to what kept us safe and what kept us regulated. So it makes sense that over time, whether it's breastfeeding or whether it's just holding a parent's hand, right, all those kind of things can be powerful non-pharmacological ways to help cope. Then skin-to-skin contact, again, similar idea with kangaroo care. Rocking and using oral sucrose, so like sugar by mouth, whether it's like sometimes putting it on a pacifier or kind of squeezing it in the mouth. That has shown in different research studies to be, again, as equal as Tylenol for helping kids with that. And singing, humming, talking softly has been another kind of level of like kind of connection that it can help people kind of managing pain, or little babies and infants to do that. Then thinking about kids, some of the similar, things we would imagine. Distraction, like tablets, as we can see, right? Not surprising. Music and touch, like we were talking about, a maternal touch or a parent-caregiver touch. That's where positioning and holding hands can be really important. The one thing that I wish we could really change in the healthcare system is restraining children during procedures, pokes, immunizations, anything like that, because that's just the trauma that is then repeated and repeated and repeated and creates the 10% of adults, at least, who are needle phobic, who don't go to the doctor and they don't get their care that they need. And then it's a lot of that reactive medical care instead of the preventive medical care. So finding ways to access, whether it's Child Life, hopefully, that might be available, or other resources like online. One of my favorite websites is megfoundationforpain.org, and they kind of have tools for little kids. They have tools for teens to think about how to prepare a game plan for these different things to help feel more self-efficacious, feeling like you have more confidence in going into these kind of procedures. So that's definitely something that we want to consider. Hypnosis, biofeedback, and humor. So this is just one version of biofeedback, and we'll talk a little bit more about it, kind of measuring skin response. So how we can use these things even for kids. Another big thing with kids and teens is that language and what we would call kind of parental empathetic attention. So we really want to be careful about the language you use because that's very powerful. And so we want to avoid things like, are you okay? What's your pain level now? What about now? What about now? Because that's going to bring attention to the pain and just reinforce the pain, right? But it is a natural instinct because that's what you've been doing for years, to save, rescue, fix, make the child feel good. That's just the evolutionary caregiver response. But now when it's becoming something like this, we have to think about how do we modify that to be still supportive and caring, but not being overly into that. Or not like, oh, I'm so sorry I'm hurting you, or I'm so sorry this hurts. Because, again, if we're apologizing for something that is necessary and your caregiver is like, I'm sorry, well, then what's dangerous? Why are they being upset? Why are they being sorry? Is something wrong? And then that just triggers that fight, flight, freeze in ourselves. So we want to kind of acknowledge, they can say, this is hard. It's okay to cry. I'm nervous too. What can we do to kind of choose to do this? Do we want to blow bubbles, or do we want to, watch a video? And giving that forced choice decision-making is another kind of classical tool. And if we can, we want to change and instead kind of talk about functioning. So still show love and care, but what are you up for today? What do you want to do today? What can we do today? So it's still kind of connecting, but not focusing on the pain. We also want to see as much as we can to encourage self-efficacy. So especially in pain populations, that's what we want to see. What can be modified, what can be more manageable that the child can do, so it's not always accommodating the pain and getting them out of different things, but finding ways to maybe make things easier to succeed at that and then build upon it. Okay. And then thinking about teens and older adults and adults, all the same stuff. We can also include even kids can do this too, mindfulness or meditation, acupuncture, humor, and then you definitely have to modify as appropriate or as needed, right? Depending on the level of functioning or mobility or other stuff we want to be mindful of. So then kind of getting more into the categories of the kind of coping skills. So basics, we want to start with the basics, distraction, right? So with kids, again, my bias or my, focus, kind of playing peekaboo, reading books, blowing bubbles, even distraction that can be interactive or passive. Some research has found that they're equal. So whether a child was playing a video game during something or was watching someone play a video game, it was still reported more or less equally of helping with that pain management during that time. Watching cartoons while getting a procedure or something was another thing that they had the research to show that it was helping these patients report lower scores on pain. And then, but the timing is super important, where it wasn't just right after, what we would think about positive reinforcement, good job being at the doctor, here's a sticker or a cookie. For pain management, we do want positive reinforcement for doing things, but for reporting lower levels of pain, it's distraction during the kind of procedure or right before. And so that's what we want to be mindful of if we're talking about pain management. Speaking of pain management, and a good example, I'm going to have a little video that I will hopefully bring up correctly. We'll see. see if I can. The volume, let me see if I can. As we can hear like singing, the humming, using the needles to kind of make it playful and desensitize, getting the baby used to it. Adding different pressure at different places like the feet and stuff.
Are you kidding me? Can I make an appointment for myself?
Yeah. All right. So that kind of just goes to show, right, that how long did it take for him to do that for that little patient? A minute and 30 seconds, basically, right? But it was taking just that little bit of extra time that made a world of difference, right? Not screaming, right? So that's just something to consider. It's not going to always be that way, right? But even if it's like a lesser of a response, because tears are fine, but we don't want flailing and we don't want that full fight, flight, freeze response. But just taking a little bit of extra time was able to make a big difference. And that's hard in our healthcare system because it's all about like going fast. And so if as a patient or as a family member or parent, we can advocate that this is what helps the patient to cope better, bringing that kind of game plan document or bringing this kind of evidence or like knowledge can hopefully help you yourself advocate to make it a less stressful experience. Again, not zero stress, but less stressful. And that can something be just really helpful. Yes, and so now next, kind of thinking the good old diaphragmatic breathing, right? Slow breathing. And so there's so many different versions and types. Blowing bubbles like we saw and we see here, right? That can be helpful not only as like a visual distraction, but again, practicing the diaphragm breathing part, slow breathing. We want to, other ones are, I've talked about like finger tracing breathing, where we slowly breathe in as we go up a finger, slowly blow out as we go down, kind of slowly with both hands, or 5 fingertip breathing, where as we inhale, we touch the fingertips together. As we exhale, we let them go. Just making sure to do it slowly, and it brings in that sense of touch, which sometimes helps kids more than just like, you know, kind of just like noticing your breath, which is like, what are you talking about? So that can be something, and in the immunization literature, again, it's shown that these things can be more effective than numbing creams or other kind of aspects too. So something to kind of keep in mind, or also the paced breathing, box breathing that involves some pauses. And these things are helpful because it's also kind of subsumed in that cognitive behavioral therapy, some of the behavioral part of CBT. Or we see that as helping get into the present moment for things like mindfulness, for things like meditation, for things like hypnosis and yoga. So we know that this is something that is a foundational aspect. Something else, again, if appropriate, if it's possible, you know, depends on patient to patient, but progressive muscle relaxation sometimes can be something else that brings us awareness to our body and helps us kind of like tighten muscles for 10 seconds, but then making sure we loosen them for 10 to 20 seconds. And so this is something that is building that awareness, bringing that attention on purpose for strategies. So that's a big key thing, is then again that purposeful awareness and like practice, because we can use a stress ball, right? And like it's there, and that's like a distraction, but it's not bad for us, but it's not going to last after I put it down, right? It stops, and then I pick it up again, and then, okay, it's not as strong. But if we put in more effort purposefully to notice how our muscles feel if they were tight, how they feel when they're loose, that builds that kind of awareness, brain-body connection that can be tapped into for more permanent kind of lasting effects. Then biofeedback. So can be a lot of different things. It's monitoring a physical function. That could be breathing, could be heart rate variability, could be the fancy name galvanic skin response, aka like sweating of our skin. So those things can be monitored and can be then changing in the moment. So that's what it can provide immediate feedback if you're hooked up and having the right equipment, having the right programming to be able to do that. It's non-invasive, which is always nice, and that it can not really have side effects that even meds like Tylenol have, right? So that can become some of the nice part. It just takes more effort than just like taking a pill, but it can have more effects in different ways. Sleep hygiene is another big thing we talk about when we think about ways to help with pain management, and it's basically having ways to help regulate our circadian rhythm, that kind of daily rhythm, 24, 25-hour rhythm of wakefulness and sleep. And so, again, not that it has to adhere to something this timely or strict, but just to have an idea that we have this rhythm and that we want to eventually, especially with kids, but even as adults, train our bodies to connect and our brains to connect the bed only to sleep. So not like playing games, watching TV, tossing and turning all the time. We have to find ways to make sure that we are being able to connect the bed to sleep so that it can be more kind of successful and adaptive. Because we know that if we're not sleeping well, right, we're not the most fun people to be around in the morning. Right? That's why we need our, cup of joe. But we want to kind of make sure that we're finding ways to help ourselves sleep better, because that also is going to affect our pain, right? We're just more sensitive, and we've become sensitized if we're not getting good sleep. Then kind of now more cognitive strategies, thinking about imagery. And it's a huge family of strategies. And I think, again, it could be, as it says, guided imagery, visualization, like with sports, right? People who do that, mindfulness, meditation, hypnosis, even contemplative prayer. All these things are kind of tapping into that power of the brain, using our imagination, but noticing all the five senses usually is a theme that they bring in. Or, a lot of times it's encouragement to find a positive location or a safe place where you feel comfortable and happy. And so that's a common theme. And we've seen that it helps patients, like at least pediatric patients, the study looking at sickle cell pain, where they were reporting that they were able to have more self-efficacy in how they manage their body and pain, decrease in how intense the pain is, and decrease analgesic use, just medicines that help decrease pain, remove pain. And so those were kind of helpful data points. It didn't necessarily reduce maybe frequency as much as intensity. So we have to acknowledge that none of these things are magic, but they can be really helpful for long-term kind of effects. Then it also helped people with around perioperative pain. So before, during procedures and stuff like that, they were seeing benefits. Then next, mindfulness. So I like to kind of base how I talk about mindfulness and what John Kabat-Zinn, who's like kind of maybe like the father of modern mindfulness, says, like how it's paying attention in a particular way, on purpose, in the present moment, non-judgmentally. So that's a big piece, is that we don't want to judge ourselves for, how we're doing, because we're gonna, quote unquote, mess up or get distracted. That's just the human brain, right? But each time we bring ourselves back to the moment, and each time we bring ourselves back to the activity, that is actually like flexing our brain muscle, like neuron connection. So it's actually the right thing to do. So we want to take away that judgment that comes with it. So usually those kind of interventions involve, breathing, meditation, movement exercises to help enhance and develop this kind of awareness of the moment and being compassionate. Again, that non-judgmental kind of focus. So a meta-analysis, just a big study looking at different studies that looked at mindfulness, has found that it can increase and make changes in the different parts of the brain. I won't go into that too much, just because it's, we have more to discuss, but that has been some of the things that folks have found. So we want to tap into that power as well. Another way to tap into the brain power, different kind of thing about hypnosis and hypnotherapy. So this is not, I like to make sure, not like stage hypnosis, or we're not going to like quack like a duck or that kind of things. This is like people who should be trained clinically and, in the lane that they are doing it in. Dentists are going to help with people who are afraid of dental procedures. Psychologists will help with different pain or other procedures. If there's a trauma worker, they're going to help with trauma. But a dentist is not going to be working on trauma. Like, that should not be what we're doing. But we have to kind of do it clinically and appropriately. And it's just being in a state of focused attention that can make and leave us more open and responsive to suggestions based on our treatment goals. So of course, I'm going to focus on pain management, but some people use it for smoking cessation, for weight loss, for enuresis, so peeing at night, for little kids and stuff, and it's helped with those things. People are not asleep or unconscious, or people are not magic or mind controlling, and it can just help us kind of be able to disassociate in the sense of like in a controlled way, not in a uncontrolled way, but like here and then, now and there, and be able to kind of make that separation a little bit. And it's been found to help in migraines and recurrent abdominal pain, sickle cell disease, and other kind of pain management areas. Another up-and-coming modality is virtual reality, because as technology has become more accessible and cost has decreased, people are using it more and more. Right now, it's a lot of times used like pre-operatively, post-operatively, or getting to the OR. And it's almost like a more immersive distraction for now, but I think in the future, we could even, different programs could be created and different things could be practiced even more so to help build kind of not just a distraction version, but like practicing your coping skills kind of version. Then kind of getting into cognitive behavioral therapy, CBT. And so this is where we're trying to kind of make changes based on our interpretation of pain, changing what's possibly distorted thoughts. Again, that's a little bit of a judgmental way of that CBT kind of looks at things, because if people have chronic illnesses where, a fracture could easily happen by stepping wrong or something, that's not a distorted thought, that's a reality. And so we want to kind of still work with how do we not get overly fearful, but how do we balance that and maybe challenge that so that our behaviors and emotions don't amplify our pain and don't get in the way of us using our coping skills. A lot of times it's trying to like identify the thinking traps that we can have, these like different cognitive negative thoughts, make them positive self-talk. But I like to say it's not that toxic positivity, like where it's like, don't worry about it, it's no big deal, you're gonna be fine. Because that's not being honest. That's not being authentic, right? That's just gonna trigger a fight, flight, freeze response from someone. We have to be realistic where this has been so hard for so long, and that now you might have the team approach to slowly and surely with time get better and better, right? That's the kind of positive self-talk that we're going to be imagining. And because we know that thoughts can influence our body's response to any type of pain management. I've seen and I've heard where people, kids are so in their fight, flight, freeze, screaming and flailing that getting injected with morphine doesn't make a difference. Or, getting all these different kind of, trigger point injections or other things that Dr. Neves talked about, they are so amped up that that nervous system response overrides the power of that medication. So we know that our thoughts and our nervous system can really influence us. And even PT and OT can become part of almost like cognitive behavioral therapy, because we're challenging some of those negative automatic thoughts that can come up. That like, oh my God, I can't do this, or I can't do that, or I will definitely, if I fall, this will definitely happen. Or so by doing things, hopefully again with a gentle, slow, understanding physical therapist, occupational therapist, it can be that data that helps decrease that intensity of the fight, flight, freeze response and get us more in rest to digest. And it can build that self-efficacy that we also strive for. So I'll get through these a little bit over for the presentation part, but ACT, acceptance commitment therapy, is another big one where it's in the family of kind of a newer version of CBT, but looking at it not so much about pathology or like distortions, but more non-judgmentally, where the goal is to create a rich and meaningful life that's kind of, they like to say, full of vitality, while accepting that pain, of course, is a part that inevitably goes with being alive. And striving for psychological flexibility and working with your values and creating committed action based on your values to live out your life. And in pediatrics, it was also an important factor that could help caregivers as well. So I won't go into it too much. It's kind of this kind of little fancy things, but I think visuals can be helpful. So, we're striving for psychological flexibility with these other kind of things that can help us and be more adaptive. But there's also the kind of other part that came out blurry, but the other things of being inflexible or not living out our values and just doing things either avoidantly or impulsively, and all that kind of things can help us or can perpetuate things that just make pain a lot more susceptible to happen or at a higher intensity. And last but definitely not least is thinking about family therapy or parenting strategies, because again, HPP and any other kind of these diagnoses are going to affect the entire family. Pain is going to affect the entire family unit. And we know that family dynamics can be influencing pain. So that kind of parental empathetic attention we talked about, then also it could be where, changing the way we reinforce things and having small manageable things to work on, whether it's coping skills or chores or activities, instead of that just, suck it up kind of mentality. We find that balance of being firm and having expectations, but also still being warm and caring and validating what the patient or other person is going through. And then we want to be careful about that kind of, again, too much care and a rescue by bringing a lot more attention to it, which is the natural parent instinct, but it kind of decreases self-efficacy, and we want to slowly build self-efficacy for patients. And then also not invalidating just by saying deal with it, and also being careful about the role that that person plays in the family, or what different roles people play, because a lot of times we see how patients can play a kind of patient role or a sick role, or that kind of, and we want to be thoughtful. Are we happening to perpetuate that? Again, a lot of this is not purposeful at all. It just is inadvertently what happens. So we want to just bring awareness to it to help kind of change it. And another thing that's important to keep in mind is that being either, caring for a child who has any of HPP or other kind of concerns with the needs of other family members and the stress and fatigue and anxiety and all that can bring, it's also that eventually at some point, taking care of oneself, whether it's a parent, caregiver, or sibling, is an important factor too, because that's the path to give the best care to the child or to the patient who needs it. Okay. So fast things, which thank you is to my mentor, Dr. Mark Popenhagen, who helped with slides in the past and helped me kind of come along as a pain psychologist, and then leaving it open to any questions.